Assalamu alaikum and very good morning, dear students. I wish you stay blessed, healthy and safe at your places. Today we will discuss about the liver infections. Objective of today's lecture is to know about the viral conditions, brief review of the viral condition hepatitis A, hepatitis B, C, and the surgical relevance with these viral illnesses. We will also know about the ascending cholangitis and all the types of the liver abscesses. So, viral hepatitis, the detailed and comprehensive view of the viral hepatitis you will learn in the medical department, but the surgical aspects of these viral illnesses and the impact on our surgical practice we will discuss here. As all of you know that it is a major health problem, viral hepatitis. There is a specialized department, gastroenterology and hepatology, that deals with the diseases of this hepatitis and liver pathologies, and the most important and the in terms of prevalence, these are the viral illnesses. Commonly we know that the acute and chronic liver diseases are produced by the hepatitis A, B and C. Hepatitis B is not very much important and significant because of the nature of the disease. Most of the time we will discuss later on, because this is self-limiting, but the complications and the things associated with hepatitis B and C are very much you can say important, and they can result in chronicity of the disease, and there are other complications associated with these hepatitis B and C. Other hepatitis also have been isolated, and amongst them is the hepatitis D and E. Hepatitis D is only detected when there is a active hepatitis B infection, and hepatitis E, which produces a self-limiting hepatitis, and it has a, like the hepatitis A, fecal route. Now the hepatitis A, as I already mentioned, that this is a milder form of the hepatitis, and the patients usually presents with anorexia, weakness and general malaise for several weeks. So anorexia is one of the very important symptomatology in most of the liver diseases. Along with the anorexia, weakness is also one of the important symptoms in the liver diseases, and general malaise for several weeks. Then there is a development of clinical jaundice. So there is an incubation period, and milder symptoms and non-specific symptoms are initially present, and then there comes the clinical jaundice. It is most of the time is accompanied by the tenderness on palpation, and there is a hepatomegaly. So this is combination of the jaundice along with the tenderness and hepatomegaly. This is the one of the clinical, you can say, diagnosis on these bases. It is the viral illness that is spread by the fecal oral route. In hepatitis B and C, the route is most of the time it is a blood-borne, and in hepatitis A, this is a orofecal or fecal-oral route. And in close communities, when and especially in the areas and localities where there is a thick population in a you can say small area, then the chances of this hepatitis A are more. How will you diagnose this hepatitis A? This is by the LFTs, and on the basis of the clinical grounds, symptomatology of the patient, LFTs, and during the LFTs we can also have take the help with the viral serology for hepatitis B and C. And again, if they are negative and we want to confirm antibody against hepatitis A, it can also be done to rule out the disease. Now in the stages of the disease. When there is a acute hepatitis, then there will be elevation of the bilirubin and transaminases, 3 to 4 times elevation of the transaminases, ALT and AST is present, and bilirubin can be raised. It can have a different manifestation in different patients. Most of the time this is moderately, and it is the value of the bilirubin is moderately enlarged. Now the management of this hepatitis A, it is self-limiting disease, but in the acute phase we have to give patient the supportive therapy. The supportive therapy can be we can ask the patient to have plenty of fluid, and if there is some we can have some in order to lower down the transaminases, we can use some drugs also. And most of the times it is a symptomatic treatment that is given, or the supportive treatment, and reassurance is all that we can give the patient. But we have to rule out the to see that if the patient is not going into some complication, and the complication is permanent liver failure, so we have to keep an eye on the liver functions also. So once a patient is recovered, it is a cure from this disease, and there is no other complication like the chronicity is present in these hepatitis A illness. Now the surgical relevance of this disease. What is the surgical relevance? Why it is important surgically? It is important because if we are working for a patient for an elective surgery, and we find out that this patient is suffering from this hepatitis A, then we have to postpone that surgery. Why we have to postpone? Because in that phase the patient's one thing is that the liver is not functioning properly, and there is a risk of further damage due to operative procedure, due to the anesthetic drugs that are used. So it is better to postpone that patient for 4 to 6 period. For emergency cases, we can use the help of some gastroenterologist, and we have to optimize the fluid requirement in that patient, and in special circumstances we can do the emergency surgery only. Now the hepatitis B, it is a more serious condition as compared with the hepatitis A. Why it is more serious? Because it is most of the time it is self-resolving. In most medical books it has been written that more than 90%, even 99% cases can be spontaneous resolve, and it is 1% case of the hepatitis B that goes into chronicity. But there are different other studies that have a different projection. So but definitely there are chances of going into the chronicity of the patient with hepatitis B. The hepatitis greatly increases the risk of one of the most life-threatening, or you can say serious complication of this hepatitis B is a development of the primary liver cancer, and the duration is very important. You must remember when the incidence, what was the first, you can say, signs of the viral illness and the development of liver cancer. Usually it takes 20 to 30 years to develop the liver cancer after the first incidence in which there was a viral, you can say, there was viral infestation in the patient. Now the clinical manifestations of this liver disease along with this hepatitis B is like all other viral illnesses in most of the non-specific symptoms: malaise, anorexia, and right upper quadrant pain. And clinical jaundice is if there is a active hepatitis. In majority of the patient does not have this obvious jaundice. So majority of the patient, they are asymptomatic. Only non-specific symptoms can be present in you can some proportion of the patient, it is not universal because to have these all symptoms. Now the complications of this hepatitis B is a liver cirrhosis and hepatocellular carcinoma, and the liver cirrhosis and although this liver cirrhosis is one of the in terms of prevalence, it is more prevalent in the hepatitis C, and hepatocellular carcinoma, it is more prevalent in hepatitis B, but obviously it can also lead, hepatitis B can also lead to the liver cirrhosis, and hepatitis C, obviously after the establishment of cirrhosis, it has a ability to convert that cirrhosis into the hepatocellular carcinoma. Now along with these presentations, patient can also present with the complication of cirrhosis like the ascites and variceal bleeding. So these were the manifestations or the symptomatology and how the patient can present to you. Treatment is with the antiviral, and of course according to the stage of the disease when the patient presented to you. For asymptomatic patients, you have to do the workup and to see the what is the status of the liver. If the patient is in decompensated liver disease, then you have to treat accordingly. So the treatment depends upon the stage of the disease, in which in the asymptomatic patient you have to do the liver function test, and to see if they are disturbed, then you have to give the proper treatment. Antiviral therapy, nowadays there is a drug treatment is available in the tablet form, and these are very much effective, and about in hepatitis C, in 4 months, if we use these drugs, that can be negative, and the patient is free of these viruses. There is more than one antiviral drug is available in the market. In the patient with cirrhosis, we will treat the patient on the protocol of the treatment of the cirrhosis. We have to restore the physiology as much possible with the help of the insult that have been taken in that patient. Specific complications we have to treat if they are present in the patient, like portal hypertension and ascites. We have to treat these complications also. Now the role of liver transplantation is very important in patients when the liver have become decompensated and medical treatment is not coping with the patient's requirement. We should think about the liver transplant. Now the surgical relevance. What is the surgical relevance of this hepatitis B? Two very important things about the surgical relevance is a increased chances of needle prick injury when the surgeon is performing for any surgery and related or unrelated with the liver. In any surgery, if the patient is doing some laparotomy or some orthopedic surgeon is using other techniques, so there is chances of needle prick injury, and the transmission rate of hepatitis B is maximum. If we compare the three conditions, hepatitis B, hepatitis C and HIV, the rate of infectivity is maximum in hepatitis B, and then it is followed by hepatitis C and then HIV. So this is the importance, and due to the vaccine available, all the surgeons, all the medical profession, these must have this immunization. So, and if there is a patient we are operating on hepatitis B and for other reasons, then surgeons should equip oneself with all the universal precautions, that is use double gloving, use of special glasses and the double mask. So these are and there are certain other techniques in which the chances of needle prick injury are minimum. So this was the surgical relevance. Hepatitis C, again, it is one of the most common cause of chronic liver disease worldwide, especially in South Asian countries. The hepatitis C is the most common cause for the chronic liver disease, and with the use of screening test, this asymptomatic patients we can identify, because it is mandatory for all the patients who have to donate the blood to go through the screening process, and in screening process hepatitis B, C screening is mandatory. Now the transmission, hepatitis B and C are transmitted through the blood-borne route. It is the route is not orophycal, it is only by the secretion, and most important is a blood-borne disease transmission. Why it is more serious than hepatitis B? In hepatitis B there is a vaccine is available, but in hepatitis C there is no vaccine is available. So this is the importance. We have to adopt all the precautions while dealing with the patient of the hepatitis C. In acute, there may be many manifestations of the patient. It can, most of the time the patients are asymptomatic. Sometimes they present to the general physician or the medical specialist in the acute hepatitis. According to the status, patient have symptoms. In acute hepatitis, patient may have jaundice, patient may have anorexia, patient may have vomiting and some pain in the right hypochondrium. Complication, obviously, hepatitis C, it can lead to liver cirrhosis, and ultimately this liver cirrhosis has the potential to convert into the hepatocellular carcinoma. For majority of the patient, we have, while we were discussing about the hepatocellular carcinoma, we have already mentioned that the single most important risk factor for hepatocellular carcinoma is the viral infection in hepatitis B and C. Now some patients can, most of the time the patients are asymptomatic, but some patients may present with the complications unnoticed, or a patient is asymptomatic for many years. Now he can present in the emergency with the complications like portal hypertension, esophageal varices, or the ascites. Now the progression to chronicity is about 20%, and there is if the patient, most of the time if the patient has in chronic phase, if the patient, sometimes it is compensated liver disease, and patient can live for longer times in this compensated liver disease. Sometimes the disease become decompensated, and there are it is suggested by the deterioration in the liver functions. And by liver functions, it is most important thing is, while evaluating status of the liver, albumin is more important than the transaminases. Transaminases usually determine the acute or chronicity of the patient, and the functional capacity we can judge by the albumin. Now other complications like encephalopathy, ascites, and bleeding, if this is present in patient, we must think about the liver transplantation, because in order to save the life this patient, if we will not go for the transplantation, then the chances of survival in these patients are minimal. Now the surgical relevance, like the hepatitis B had the acute, we can have immunization against hepatitis B, but sadly up till now immunization have been not developed against the hepatitis C. So we should be more careful about handling the patients with the hepatitis C while performing surgeries related with the liver or unrelated with the liver. Any surgery in a patient who is hepatitis C positive, it should be the surgeon should be equipped with and take care of the universal precautions And what are the universal precautions? These are the using of double gloves, then using of the special glasses, and then there is a special surgical techniques in which there is a minimal handling of needles and the other instruments. Now there is a definite role of liver transplant in the patients who are not responded to the medical treatment. Now other conditions, other infective conditions, and especially the biliary passage that involve these are the ascending cholangitis. After the viral illness, these are the bacterial infections, and the terminology that is used for bacterial infection that involve the biliary tree, especially the common bile duct, common hepatic duct, and the whole of the biliary system, is ascending cholangitis. And in most of the cases, this is associated with the obstruction at the level of the common bile duct, and this obstruction is most of the time is due to the luminal obstruction by some stones. So in patients who have stones, cholelithiasis, stone in the common bile duct, these patients can have superadded infection. Why there is infection in these patients? Due to the stasis of the bile, and this stasis will lead to the infection, bacterial infection. The clinical manifestation of these patients is clinical jaundice, rigors, and tender hepatomegaly. So this is a specialized, you can say, we can have this three important things: jaundice, rigor, chills and fever, and a tender hepatomegaly. So this is a classical, you can say, symptomatology and signs of the ascending cholangitis. Now for diagnosis, we will take help from the radiologist, and on ultrasound there are dilated bile duct. Normal diameter of the bile duct is 7 millimeter. Most of the time when it is dilated, it can go up to the 10 millimeter, 12 millimeter, and along with this dilated bile duct there may be stones present, and that is causing the obstruction, and then there may be stasis, and this lead to the ascending cholangitis. On LFTs there will be obstructive picture, and what we mean by the obstructive picture? It by obstructive picture means that the alkaline phosphatase level will be 3 to 4 times higher than the normal. So the level may be around in 1000 or more than 1000. The rest left is mean ALT, AST, and bilirubin. Bilirubin will be definitely raised in this patient due to obstructive picture, but the ALT, AST will be mild to moderately raised to the normal level. Another important thing about the diagnosis is the isolation of the organism from the blood. So blood culture is very important in these patients. Why it is important? Because we have to initiate the antibiotic therapy according to the culture report. Now the treatment, it is a medical emergency, because if the patient is untreated, then there is chances of organ failure due to septicemia. First line antibiotic, broad spectrum antibiotic, is used initially until unless the culture report, blood culture report is there, and we have a antibiotic according to the culture and sensitivity. Usually these are the antibiotic, broad spectrum antibiotic. We can have a combination of more than one antibiotic, and the standard treatment protocol for the biliary infection is a second generation cephalosporin. This is the recommended because the penetration of the second generation cephalosporin is maximum in the bile. The other supportive treatment in the form of resuscitation, analgesic requirement, antipyretic, these can be given to these patients. Now the you can say curative treatment for these patients is a ERCP and percutaneous transhepatic drainage. ERCP is better technique because it gives us diagnostic as well as a therapeutic and minimum chances of you can say the rupture or the other complications. But in cases of percutaneous transhepatic drainage, there are chances of parenchymal disruption of the liver. So ERCP along with sphincterotomy and removal of the stone is a standard treatment for ascending cholangitis along with the antibiotic treatment. Now the liver abscesses. Etiology of the liver abscesses is unexplained. Initially it is unexplained, but we have to search for the exact reason. In most of the cases, it is present in elderly patients and diabetics and immunocompromised patients. Why it is present in these patients? Because these elderly are also immunocompromised, diabetics are also immunocompromised, and patients who are taking some immunosuppressive therapy for patients who have a liver or renal transplant, they are on immunosuppressive therapy, or for other autoimmune diseases some patients are on immunosuppressive therapy. So the chances of development of liver abscess in these patients is maximum. So in history we should ask about any medication, any systemic disease in order to reach for the risk factor for the development of this liver abscess. Now the clinical manifestation, like other liver disease, we have discussed that the anorexia and malaise are the two cardinal features in most of the cases of the liver disease. Fever is very important because whenever there is a pus formation, fever is a part and parcel of this pus. Along with this fever and other symptoms on clinical examination, there will be right upper quadrant discomfort. The diagnosis is mostly, it can be, initially we can have a picture by the ultrasound, and information we can get from the ultrasound, but the CT is more accurate in you can say establishing the exact size, and the other differentials we can also rule out on the CT scan. Here you can appreciate this is a cyst, and along with this cyst there is a air component is also present, and this is a most of the time while knowing the cyst in the liver, there is another pathology is present in that liver. Now the pathogenesis of this liver abscess, most common organism, these are the Streptococcus malariae and E. coli. There are other organisms can be present in patients, Streptococcus faecalis, Klebsiella and Proteus vulgaris. So, and the opportunistic organism in patients with especially the diabetes, staphylococci can also be present. So why these organisms are important? Because we will give treatment, we will have antibiotic choice according to these microorganisms. Usually penicillin, aminoglycoside and metronidazole, this is the combination. Triple regime, this is a triple regime, classical triple regime is given to the patients, but along with this triple regime we can have this cephalosporin and metronidazole combination can also be given in these patients. Along with the antibiotic, analgesics and other therapeutic agents, we can have a ultrasound guided aspiration of the abscess. If this facility is available, then we can, along with the aspiration, we can have a culture and sensitivity. Ideally, after the culture report, we can switch over to the exact antibiotic that is matching the microorganism. For all the liver abscess, we must sort for the source of the liver abscess. Sometimes there is another pathology is present in the colon, and we must look for that pathology. Now the other liver abscesses, and two very important liver abscess, these are the amoebic liver abscess and hydatid cyst. Now the amoebic liver abscess, it is caused by the Entamoeba histolytica. It is endemic in many parts of the world. It exists in vegetative form outside the body, and it is spread by the fecal-oral route. The most common presentation of this amoebic liver abscess is a dysentery. The where does the amoebic liver abscess form? Most common sites are the paracecal and in the liver. The amoebic cyst is ingested and develops into trophozoite form in the colon, and then it passes through the bowel wall and liver via the portal blood, and where it finally accumulates. Now the diagnosis of this amoebic liver abscess is the isolation of the parasite from the liver lesion. This is done with the help of the interventional radiologist that can help in order to take the aspiration of that particular site. The stool examination, complete stool examination, will also tell us about the nature and of the ova that is present and about the microorganism. Now the treatment. The patients with amoebic liver abscess often presents with the abscess, and they are treated empirically with the metronidazole, and the recommended dose for amoebic liver abscess is 400 to 800 milligram thrice a day, and the duration of the treatment is 7 to 10 days. So metronidazole, commonly known as flagyl, it is given in a single tablet thrice a day or double tablet 400 or 800 milligram thrice a day, according to the severity and the response of the disease. Now the final today's final, you can say, topic, that is the hydrated liver disease. Hydrated liver disease, the common condition in countries around the Mediterranean, and the causative tapeworm, that is Echinococcus granulosis. This is the causative tapeworm parasitic infection, and it is present in dog's intestine. Ovas are ingested by the human and pass in the portal blood to the liver. So this is again the orophycal route. Is hydrated liver disease has a orophycal route. Liver abscesses are that are hydrated, that are caused by the this Echinococcus granulosis. They are most of the time very large at the time of presentation, because initially the patient does not have any symptoms. Whenever the patient presents, they are due to some trauma to this area, and whenever there is trauma, then there will be discomfort in the right upper quadrant, and due to the rupture of this large cyst, there will be acute abdomen picture. And what is acute abdomen picture? Just like there will be severe pain, abdominal and distension, then there will be on examination tenderness whole of the abdomen. Now for diagnosis, we have to rely on the ELISA technique that will detect the antibodies, and then on the CT scan and ultrasound. These are also helpful. In ultrasound, there are multiloculated cysts, so there are multiple patches of the fluid filled cavities in the liver. And on CT scan, there is a floating membrane. Here you can appreciate that this is a membrane. This is a whole of the cyst, that is there is a capsule, and this is a fluid, and there is a floating membrane. This is a, you can differentiate by other pyogenic abscess with this floating membrane. This is the diagnostic for the hydatid cyst. Now one important feature of this hydatid cyst, one large cyst sometimes contains daughter cyst, and when they rupture, they have ability to implant, and they can grow, and full-blown picture of the cyst can grow at other sites where these daughter cysts have been implanted. Now the treatment of this hydatid cyst, there is a medical treatment in the form of albendazole and mebendazole, and for smaller cyst, if the size is smaller, then we can use the percutaneous treatment, and after initial treatment of the albendazole. So there is a specified term for the treatment of the hydatid cyst, that is PAIR. What we mean by the PAIR? This is the puncture of the cyst under image guidance, then aspiration of the cyst, then instillation of the hypertonic saline in the cyst and re-aspiration. So it is a combination of 4 to 5 procedure that is done in the same setting. सबसे पहले हम जो cyst होती है उसको पंचर करते हैं अंदर image guidance means under the ultrasound guidance or CT guidance. Then we aspirate the cyst contents in the same, after puncture we aspirate, then after full aspiration in the same needle and the same you can say in the same tubing system we instill the hypertonic saline and then re-aspiration. So this is a treatment for the most you can say minimal invasive ये technique है जिससे आप जो है वो without use of anesthesia safely we can do treatment. But if the patient is not responding, there is a reformation of this cyst, then we have to go for the surgical intervention. And the surgical options are the resection, liver section, or local excision of the cyst. The danger in the local excision or the surgical resection is that there is chances of rupture because of the size is very much increased, and when there is a rupture, then the chances of reimplantation in the peritoneal cavity is very much there. Now in order to prevent from this contamination, the patient should be infused with the albendazole and mebendazole at the time of surgery, and peroperative praziquantel is also added. And along with this drug treatment we have to pack the peritoneal cavity, so we will place some abdominal sponges all around the liver so that if there is a contamination, and along with this packing we also the saline soak bag we have to instill the hypertonic saline into the cyst. Why this is given? Because in order to destroy the daughter cyst. So this was all about the today's lecture. Now the summary, we have discussed about the viral hepatitis, hepatitis A, B and C. The treatment of this is a supportive antiviral agents and liver transplant for cirrhosis, especially the hepatitis B. We have also seen the complication and the surgical relevance of these hepatitis B in terms of the protection of the operating surgeon, prevention from the needle prick injury and role of the liver transplant. Then we discuss about the ascending cholangitis, enteric bacteria. This was the causative agent, and the most important reason was the common bile duct stones, and we have to relieve this obstruction. The treatment is the antibiotics, cephalosporin, especially the second generation, and we can add some other therapeutic management like the ERCP. Pyogenic liver abscess causative agent was the Streptococcus malariae, most common. Then the antibiotics, we can give broad spectrum antibiotic, triple regime, or combination of cephalosporin with the metronidazole. Other treatment options for these is aspiration and drainage. Percutaneous drainage has the disadvantage of rupture or damage to the liver. Aspiration, again ultrasound guided. Now the amoebic liver abscess, Entamoeba histolytica was the causative agent, and the treatment is metronidazole, and the dose is 400 to 800 thrice a day for 7 to 10 days. Then the hydatid liver disease, Echinococcus granulosus, the medical treatment is a mebendazole, albendazole, and surgical treatment is resection, and we have to omentoplasty, and we have to be very much vigilant while resecting in order to avoid spillage of this hydatid liver cyst into the peritoneal cavity. So hopefully I have conveyed the message about the liver infections and the liver abscesses. Thank you very much.